In this section, we will discuss protein synthesis inhibitors. These drugs affect protein synthesis at various stages of the translation process, including ribosomal assembly, tRNA binding, peptidyl transfer, and translocation. The mnemonic to remember the protein synthesis inhibitors is bi at 30, cell at 50. The at 30 refers to the 30S inhibitors, aminoglycosides, and tetracyclines, AT. The aminoglycosides include streptomycin, gentamicin, tobramycin, and amikacin. These are bactericidal drugs. The T, or the tetracyclines, are bacteriostatic drugs. The cell at 50, that's CCELL at 50, refer to the 50S inhibitors, including chloramphenicol and clindamycin, which are both bacteriostatic, erythromycin, which is bacteriostatic, lincomycins, which are bacteriostatic, and linezolid, which is variable.
Another group of antimicrobials is the aminoglycosides. These include gentamicin, neomycin, amikacin, tobramycin, and streptomycin. The mechanism for these drugs is through the inhibition of the formation of initiation complex and causes misreading of the mRNA. They do require oxygen for uptake, and therefore they're ineffective against anaerobes. They are bactericidal in nature. Their clinical use includes severe gram-negative rod infections, and they're also synergistic with beta-lactam antibiotics. Neomycin is used mostly for bowel surgery. Their toxicity profile includes nephrotoxicity, especially when used with cephalosporins, ototoxicity, especially when used with loop diuretics, and teratogenic effects. Resistance to these drugs involves transferase enzymes that inactivate the drug by acetylation, phosphorylation, or adenylation. So a good mnemonic for this is mean gnats cannot kill anaerobes. So gnats, G-N-A-T-S, are your aminoglycosides, gentamicin, neomycin, amikacin, tobramycin, and streptomycin. And remember, they cannot kill anaerobes. They require oxygen, and that not in cannot, if you remember, is for their toxicity profile, nephrotoxicity, ototoxicity, and teratogenic effects. Next, we have the tetracyclines. They include tetracycline, doxycycline, dimeclocycline, and minocycline. These are bacteriostatic agents that bind to the 30S subunit of the ribosome and prevent attachment of aminoacyl tRNA. They have limited CNS penetration. Doxycycline is fecally eliminated and can be used in patients with renal failure. You cannot take any of these drugs with milk, antacids, or iron-containing preparations because the divalent cations inhibit the absorption of the tetracyclines into the gut. Their clinical uses are for the following organisms: Vibrio cholerae, acne, chlamydia, ureaplasma, ureolyticum, Mycoplasma pneumoniae, tularemia, H. pylori, Borrelia burgdorferi, or Lyme disease, and rickettsia. So you can remember this: vacuum, the bedroom, V for Vibrio cholerae, then acne to treat acne, chlamydia, ureaplasma, ureolyticum, Mycoplasma pneumoniae, tularemia, H. pylori, and then to the B, that's Borrelia burgdorferi, and to the R, rickettsia. The toxicity profile for these drugs includes GI distress and discoloration of teeth and inhibition of bone growth in children. It also causes photosensitivity. For this reason, it's contraindicated in pregnancy because we don't want to affect the teeth and bone growth of children. Resistance to tetracyclines involves the decreased uptake into cells or increased efflux out of cells by a plasmid-encoded transport pump. Again, just a note on the dimeclocycline. This is an ADH antagonist, so it actually acts as a diuretic in SIADH. Next, we have the macrolides. These include erythromycin, azithromycin, and clarithromycin. These drugs work by inhibiting protein synthesis by blocking translocation. They do so by binding to the 23S rRNA of the 50A ribosomal subunit and therefore act in a bacteriostatic mechanism similar to the tetracyclines. Their clinical use is for upper respiratory infections, pneumonias, and STDs. They can affect gram-positive cocci like streptococcal infections that we see in patients, and they're especially useful in patients that are allergic to penicillin. They are also used for mycoplasma infections, Legionella, chlamydia, and Neisseria. Their toxicity profile involves a prolonged QT interval, especially erythromycin. GI discomfort, which is actually the most common cause of noncompliance, acute cholestatic hepatitis, eosinophilia, and skin rashes. It also increases the serum concentration of theophylline and oral anticoagulants. The resistance mechanisms to macrolides involve the methylation of the 23SR RNA binding site. Another drug is chloramphenicol. Its mechanism is through the inhibition of the 50S peptidyl transferase activity and is therefore bacteriostatic. Its clinical uses are for meningitis caused by Haemophilus influenzae, Neisseria meningitidis, and streptococcal pneumonia. We're very conservative when using chloramphenicol owing to its toxicities. It can cause anemia in a dose-dependent fashion and aplastic anemia in a dose-independent fashion. It can also cause what we call gray baby syndrome in premature infants because they lack liver UDP glucuronal transferase, which is involved in the metabolism of chloramphenicol. Resistance to this drug is through a plasmid-encoded acetyltransferase that inactivates it. Clindamycin, another drug, works through blocking the peptide bond formation of the 50S ribosomal subunit, and it's therefore bacteriostatic as well. Its clinical use is for the treatment of anaerobic infections like Bacteroides fragilis and Clostridium perfringens. It's also commonly used to treat MRSA. Its toxicity profile includes pseudomembranous colitis and the overgrowth of C. difficile, leading to fever and diarrhea. It's used to treat anaerobes above the diaphragm versus metronidazole, which is used to treat anaerobic infections below the diaphragm.
And that concludes this section of the review.